So let me thank everyone because of all the great work that you've done. I am in the consumer goods industry, and I've actually been able to leverage a great deal of that research in building a consumer-relevant health and weight management program for Amway, and in particular the Nutrilite brand, which, if you're not familiar with, is predominantly focused on seed-to-supplement, vertically integrated organic growth, concentrate, and then development of not only products from that, but supplements. Predominantly for health and wellness, and in this new era, we've been asked by our independent business owners to try to help address some of the concerns for overweight and obesity, which is finding its way into even our business families and their family lives. So we embarked on looking at what's in the literature probably in the early 2000s, and in partnerships with Stanford University and Chris Gardner, we were able to work directly with Interleukin Health, which worked with Chris Gardner on his A to Z study. I hope you're all familiar with his brilliant work that was done there, and is continuing to progress. And so we started our original program to look at calories in general. Yeah, that was a good big question. Calories as they relate to energy. You know, how does a calorie get converted to work and get to do something in your body? And are all calories available? Are they available for all genotypes of people? Well, we leveraged the data from the Stanford study, and if I'm just going to give you an overview of what we found. He had A to Z. A was for Atkins, Z was for Zone. He also had the Learn diet and the Ornish diet, different relationships on macronutrients, fat, protein, and carbohydrate, with the Atkins diet down at the lowest levels. When they started and self-reported their diets, they were down around 18% carbohydrate, 55% fat. When they finished, after a year long in the study, they were self-reporting in at around 35% carbohydrate and 44% fat, where the Ornish diet was starting at about 63% carbohydrate and about 21% fat, and finishing at about 52% carb and 30% fat. Now, what Interleukin genetics and Chris Gardner were able to discern was that there actually were 3 genetic susceptibility patterns that were discernible to give advantage to weight loss. So if you have the fatty acid binding protein, FABP2, you have a particular genotype, the PPARC or the ADRB2, and you had a particular pattern, and we'll call it pattern 1, you were going to be more successful in achieving not only short-term weight loss in 2 months' time, but maintaining that long-term weight loss over 12 months if you ate low carb. So pattern 1, low carb. Pattern 2 turned out to be a little bit more complex in terms of the understanding that you needed to balance across those macronutrients for your susceptibility, reduce your caloric evenly across there, and you would be more advantaged for weight loss. Well, pattern 3 turned out to be one of the ones I think we're seeing some of the sensitivities to right now with, yeah, you had all of the right genotypes for being a low-fat, macronutrient susceptible individual, but because of some maybe phenotypic parameters, you were not going to be advantaged for losing weight by eating a low-fat diet. So you had to, in pattern 3, you had to actually initiate your weight loss journey by doing low carb, and then about 50% through your goal setting, when you achieved a little bit of weight loss, your metabolic parameters probably regained their sensitivity, you were able to then convert over to the low-fat diet, which is a little bit higher in carbohydrate content. So that was a really interesting result for us as a consumer goods and product creation organization. And we looked also at not just what was going on with the calories, because we know we want to eat less. We want to now know eat less of the correct macronutrient composition for your genetic susceptibility. But we also at that time also looked at your susceptibility to energy and how metabolically active you were relative to your ADRB2 and ADRB3 genes. And what is your susceptibility for using activity metabolic activity for helping and aiding you and getting you advantage to weight loss. So we looked at a number of different parameters. We launched a USA program where we looked and targeted getting assessment of individuals that come into our program using the genetic test for both diet and exercise. And then we rolled you out with a series of recommendations relative to that genetic genotype with diet and exercise recommendations. We then rolled that to Europe and increased now the number of participants in our program and the exposure. So we're well over 100,000 people now that have come into our program and taken our gene test and have then proceeded on to their goal setting, their weight loss program per their recommendations, and then their success achievements. And I'm just going to share some quick numbers with you because these are only internally published data. That's why there's no slide for this. But it is part of the guiding force of our organization's growth and development of this program as we continue to go for improvement in quality, improvement in success, and delivery against a lot of the same metrics that we are talking about here. We have 25,000 individuals that are in the database that I'm going to speak to now. The pattern 1 population coming out of the Chris Gardner study was somewhere around 45%. So the low-carb people were 45%. That was only 300 subjects. Now we have 22,000 subjects, and we see that pattern 1 is seen in about 50% of the European Caucasian population. Pattern 3, which is that kind of confused, I got to start low carb, I'm going to be better served long term staying low fat, that population is representing in at about 35%. And the better balancer, or the one that will forever fight to lose weight because every single thing they eat, they convert very efficiently. They have really good susceptibilities to both fat and carbohydrate. That's about 15%. So if you look at that relative to Chris Gardner's study, those numbers are very close. So his A to Z study with a population of 300 people appears to have been a very nice predictive study now 7 years later in hindsight. And we're using the findings from that to go to the next level. So one of the things we're able to do now, because of big data and the understanding, and these people actually self-reporting into a digital website, we can actually now follow their choices. So what were their choices when they were told to be low-fat, low-carb, or better balancer? What were their choices when they were offered different services? Because we not only offer the assessment, we offer the products, and we offer services. And we found now that we have actually 95% success rate with 95% of the population of this 22,000 successfully losing weight in our program. We have 5% failure. Do we think we know what the failure rate is actually independently delivered against? Yes. And it was not their food choices, but it actually turned out to be their service choices. And the individuals that chose not to take on full-time coaching or not to take the electronic emails with contextually relevant feedback, they were not successful. 95% of the people, though, did enroll, chose the full service package, and then now what we can see is a little bit into the insights of the food choices that they chose. So I'm sorry, chocolate shake lovers, that one, you didn't lose as much weight if you chose it for your meal replacement flavor set versus the rich, creamy tomato soup. So there's a little bit of information that we may find as we continue to develop this program and get more insights into these self-reported choices that people are making in our program. And we just want to make sure that I let you know that the majority of the information from the interleukin gene test and the Stanford study and our massive data set with the Europeans is all in the Caucasians. So we don't really, and eating Western-like diets, we don't really have a lot of data in our Asian populations, and we are very soon going to be rolling to Asian populations with food recommendations, service recommendations, and assessment tools. So we had to adjust our assessment tool to have applicability in Asian populations. And we looked to Dr. Moen, who has a very nice IDRS, which is a very short questionnaire survey, 5 questions, girth measurement, allows you to get to undiagnosed type 2 diabetes with pretty good specificity. So we use that as one of our ways to get assessment on the diet. But we're continuing to use gene testing for understanding the metabolic parameters required to include exercise, because the thing we found going to Asia, we can't use the word exercise. So we've had to actually rebrand exercise in our programs to be physical activity. And now we have new words. And so I think Dr. Schreiner mentioned NEAT, non-activity, non-exercise activity thermogenesis. And working with Jim Levine and Mayo Clinic, we have done a tremendous amount of work. And how can we get people to understand that concept is pretty difficult for us. So we're taking on Pennington's term, and we're calling SPA our way of getting people to do spontaneous physical activity. And that one seems to be resonating a little bit closer with our folks in Southeast Asia. So we took those learnings, and we did understand that we were getting about 3% on average weight loss. And as I was saying here in these questions, we wanted to know, is it for all people, all genotypes? Well, gender too, we thought, well, there's going to be a difference here in gender. Unfortunately, we don't see a difference, and not only do we not see a difference in the goals that the men versus the women set, they all wanted to lose 20% weight. And I was like, these are so unrealistic. But that's what they had chosen, and so we don't see it's a non-delimiter in our data set. But the other thing we didn't see was we didn't see a difference in the amount of weight loss either. So the mean average weight loss across all that 95%, male or female, was about 3 weight percent. So we want to see, is there a way to get to that number of 3.5 weight percent that Rosewood has? That it's Rosewood, you guys have 3.5, yeah, and that seems to be a number where we get some tipping points for the metabolic parameters, and we start to see health benefits being re-engaged and reinitiated. So we thought, well, there's other barriers that are keeping people from being adherent to their diet or compliant to their physical activity, spontaneous activity programs. So how can we include those assessments also in our toolbox? So we actually went to the literature and we looked at, Stephen Cohen's perceived stress scale, and so we've got the permission and rights to include that. So we are actually now probing and getting a perceived stress score for individuals. We also do Pittsburgh Sleep Quality Index to get a sense of how well are you sleeping and how is that maybe impacting, keeping you from being able to be adherent and compliant. We also look at mindful eating, which is really for us self-efficacy. So how well will you and do you believe that if the delicious orange is in front of you, you won't eat it? Or if you didn't want to get up when that alarm went off this morning, you're still going to get up and go and do your fitness exercises, your stretching and whatever you need. So how efficacious are you in perceiving that? And then we also are looking at some very new literature that's coming in to show that the time of day that you eat your highest caloric content meal can significantly give you advantage to weight loss. So we have a body key index assessment tool, which is a questionnaire-based tool. It's all digital. It's really fun to do. And when you finish it, you get an instantaneous contextual feedback to who you are in a personalized way relative to 6 indices that may or may not be barriers to your successful advantage to weight loss program. Now, with that said, that's too much to talk to somebody about that's joining a program. So what we give them is a life key. We give them physical activity for sure. We give them diet recommendations for sure. Everybody gets that. And then you get your number one significant barrier that we have a hopefully patent. It's a patent pending logic algorithm that allows us to determine for each individual what is your next biggest barrier to achieving the adherent and compliant weight loss program success that you want. And by doing that, we've actually come now to understand a little bit more in some preliminary testing that it isn't as easy as we thought it was going to be, that people really are very individualistic, and it does have to be personalized. And not only that, but I can't remember who was presenting it earlier in the morning yesterday, but we have to reassess people. So a single one-time assessment at the beginning of a program is fantastic, but at the end of 3 months, when you've achieved your 3% weight loss and you're still not at your goal of 20, you still have a little bit more work to do, and it's perhaps not against the same focused stress barriers or the healthy, obsessive barrier as you might have thought. And so we have to reassess. And luckily, the tool, as it was designed, we're allowed to use this tool and reassess, and we are seeing that as people do move, as their metabolic parameters change, as their indicators or their barriers to achieving adherence to the program that's been recommended to them, they're achieving more success, and it even moves to perhaps you were sleep, now you're stress, or now you're activity. So we're really, really excited about the stuff we have, and again, it's going to be assessment, it's going to be products, and it's going to be services. So a lot of this stuff in our product realm is going to be driven by some of the work coming out of here. Thank you.